Zanariah, and I would like to shed some light into the area of insulin therapy in our patients with diabetes that fast in Ramadan. Of course, we are aware that being on insulin heightens the risk of fasting, especially for hypoglycemia during the fasting period. Yeah. So these are just my disclosures. As an outline, I'll breeze through the types of insulin available. We're pretty lucky nowadays in even Asia, in our part of the world, that we are accessible to a great many newer insulins, which are essentially safer with less hypoglycemia risk and provide essentially a possibility of better glycemic control within Ramadan. We'd like to look at the pattern of insulin use in people who are fasting during Ramadan. I'll just focus on type 2 diabetes, and studies out there. Well, a lot of them are observational, but currently now there are more and more studies designed looking at the efficacy during Ramadan. And I'm sure with the newer insulins that come, this will also be the general rule. Let's also have a look at the prior Dar Global Survey in terms of the insulin-treated patients and how, how do they fare in terms of glycemic events, in particular hypoglycemia, and really then end up just to mention and re-emphasize and remind the recommendations of insulin use in Ramadan. So, this is a nice slide. We're actually, celebrating 100 years of insulin, as you can see, and you're all aware of this. And now we're actually here, and many of us are accessible to the newer insulins, such as degludec insulin and glargine U300, and some are even accessible to the co-formulations of insulin. And we look forward, in fact, to the future where there will be further developments in insulin, and all this with the promise that the insulins will be safer in terms of minimal hypoglycemic risk, more physiological, with better postprandial control, and enabling people to have generally good glycemic control, whether they fast or they don't fast. So this is what the future promises. In terms of the insulins available, I'm sure you're all very well aware of it, and it's just to put it in front of us so that we remind ourselves that we have so many available. Some of us may be using ultra-rapid insulin, but that is more for type 1 diabetes. And most of us may be still using human insulin, whether it's short-acting or intermediate-acting. So the choice of insulin is very important, as we recognize that the modern insulins, being the insulin analogs, are able to provide good glycemic control with the most minimal hypoglycemic risk. So these are, for example, the premix analogs available. There's so many I didn't realize, because, for example, in Malaysia, we don't have all these different mixed premix insulins, which some of you may have in your countries. Yeah. But there are so many different insulin regimens that we are prescribing for our patients when they are not fasting, and they will carry on with these regimens usually when they are fasting. Yeah, most of us will confine ourselves to simpler regimens, for example, just adding a basal insulin at night along with the oral glucose lowering drugs, or maybe nowadays the fashion of having a basal plus regimen where you may retain more of your oral agents and just add a short-acting insulin with the main meal. And some actually, even though type 2 diabetes, will go ahead with very intensive regimens, for example, basal bolus insulin. But in our part of the world, Asia, we're pretty much comfortable also with using premix insulins, and more so now with the available of newer modern premix insulins and co-formulations. These are pretty flexible with less hypoglycemia. So this is just a reminder that prescribing insulin and having so many insulin regimens at hand is in fact an art and skill for us to do. So what are the patterns of insulin prescription among people who fast? So in Hospital Putrajaya last year, what we did is we attempted to use the diabetes and Ramadan risk score, and during that risk scoring. With the new risk calculator, we looked at what medications the patients were on. So it is a tertiary hospital, so we do have patients with a longer duration of illness and therefore more people on insulin. So about 70% were insulin treated. And maybe this also reflects most of what the patients in Malaysian tertiary hospitals are being managed when they have diabetes and fasting with these insulin regimens. Yeah, so more often than not, they are on a basal bolus insulin regimen, which is quite a burden for patients with 4 injections a day and probably having a higher risk of hypoglycemia and possibly also in Ramadan requiring finer adjustments. Second to the basal bolus insulin is actually a proportion of about 1/6 or so actually on the pre-mixed insulin, yeah, and more often than not is a human pre-mixed insulin, because in the public hospitals access to modern insulin analogs, including premix analogs, is quite restricted, and a fair number being started on just a basal insulin alone on top of their oral glucose drugs. So I presume this would be the way that most patients are treated, also going on to Ramadan with this treatment. So what about in the Dar Global Survey, which is a worldwide survey, and Malaysia was part of it, but these represent the data for the whole cohort. There were nearly 6,000 patients, and this represents how they were treated, and we just focus on those on insulin. So broadly, there were about 44%, not nearly half of the patients in the whole survey with type 2 diabetes were in fact insulin treated, and therefore, and this, I remind you, is a post-Ramadan survey. It was done in the 10 weeks after Ramadan, so it was actually retrospectively collecting information of how they were treated during Ramadan. And among the insulin treated, here what we see is they are also a fair number on basal insulin, and presumably a part of this was with the prandial insulin as well in a basal bolus or basal plus regimen. About a third were on prandial insulin, and premix insulin was also a common sort of way to prescribe an insulin regimen, which is about a third of patients. Yeah, so a fair number of people around the globe are fasting with different insulin regimens that may have different carry different risks. Just out of curiosity, because as we mentioned, we know the differences between human insulin or conventional insulin as well as modern or analog insulin, and it's nice to know that more people might be more accessible to the more modern insulins, which have less hypo risk and therefore safer to use in Ramadan. So in the Dar Global Survey, looking at basal insulins alone, as you can see here, a fair majority, in fact, about half of them were actually on insulin glargine. Yeah, and if we put the other basal insulin analogs there, such as levemir, and the later, most recent degludec, which may not be available in some parts or some countries. In Malaysia, certainly it's not available yet. So 2/3, in fact, of people who are fasting around the globe are accessible to basal insulin analogs, which is a good recognition that they are at least using a safer insulin. Yeah, and about a third are still on human insulin. In terms of prandial or bolus insulin type, so those fasting in Ramadan in the study, about half, in fact, were accessible to the more modern prandial or bolus insulins, what we call rapid analogs, as you can see the divide here, and another half was still on human insulin. Yeah. So the commoner, or more often, if they were on an analog, it was on insulin aspart, and the other insulins, Lispro, as well as blue lysine, were equal in use. And in terms of premix insulin, we can also appreciate here that about half or so are on a human premix insulin, and another half or so, less than half or so, are on modern premix insulin, yeah, which actually provides more flexibility in dosing, lesser hypoglycemia, and sometimes the ability to have an added dosing. Yeah, although in Ramadan we do not need the noon or day midday dosing because of fasting. More common, they were on a low premix analog. So we have an idea how people with type 2 diabetes who are insulin treated and the type of insulin they use when they are fasting in Ramadan. Yeah, so it is actually a good for us to know that many are accessible to analog insulin use. Yeah, although it is important maybe to look at the geographical divide and understand, in the patterns of prescription in different countries. So analog insulin, as we mentioned, have less hypoglycemic risk, greater flexibility in dose in terms of the timing of the dose, and we know it has better postprandial glycemic control because of the quick and high levels of rapid insulin that come after the rapid dose or the pre-mixed dose, and less glycemic variability. So essentially making Ramadan fasting with these insulins safer, and also the ability to probably get better control. From the IDF Dar 2021 practical guidelines, there are guidance into the possibilities of needing insulin adjustments for Ramadan. We recognize that insulin regimens should be individualized according to the individual's needs and taking into account their level of education, preferences, diet, and lifestyle. And this is often done already prior to Ramadan and established. Yeah? There are recommendations to switch insulin regimens possibly before Ramadan, but changing insulin regimens just only for the Ramadan period is not an easy thing to do, and it may lead to errors and patients' non-confidence and therefore non-adherence, and actually will require additional intervention in terms of education for the patient, which may possibly not be accessible due to lack of time and resources. So as a physician managing these patients, we really need to assess really whether a new treatment regimen or medication modification of the dose is required. And this must be done in the weeks or possibly couple of months prior to Ramadan. So the individual's pre-Ramadan glycemic control will really determine whether you need to do dose adjustments. Particularly, we're wary about the risk of hypo. So in fact, dose reductions are often what we want to do, particularly for the early morning dose for sahur to avoid the daytime hypoglycemia, and possibly even adjusting the iftar dose because of the probably added calories and different kind of meals that they have during the iftar for Ramadan. But essentially, if we are already able to get good control or stable and fairly good control of diabetes well prior to Ramadan, that means we've managed our patients with good education and prepared them well, and they've had a prior Ramadan experience that's good, usually there is really minimal need to, not very much need to make such major adjustments, yeah, in terms of the regimen, definitely, and also possibly the dose, yeah. So there are many clinical studies, as mentioned, of insulin therapy in Ramadan in the situation of, but mostly these have been observational, and there have been for modern insulins, more randomized control trials as well. And of course, there are information from the real world studies as well with regards to glycemic events in patients with insulin therapy in Ramadan. So there's really no time to go through all, but the guidelines of 2016 and 2021 very nicely summarize in the tables the different insulin therapy trials that are of significance for Ramadan. But I've just taken two trials because they're the later trials, and this one is the Orient study, which is actually the insulin glargine U300, which is a prospective and observational study, and authored by Dr. Muhammad, none other than Dr. Muhammad Hussein, and multi-center international. Yeah, and of course we start in the pre-Ramadan period in patients, and then they are switched to actually insulin glargine U300. We recognize already the characteristics of glargine U300, and basically most of the Ramadan studies is to look at the safety in terms of hypoglycemia during any difference between the pre-Ramadan, Ramadan, and post-Ramadan period. So I won't go through it in detail because of lack of time, but generally we actually have a look at the cohort of patients, which are typical of our type 2 diabetic patients, being in their mid-50s, yeah, with overweight to obesity and long duration of disease. And of course, once they are on insulin, they've already usually got a long duration of disease or complications, and they are having a moderate, in fact, a high level of risk, yeah, from different countries. So what is actually very reassuring is that during the study, and also what we see in the real world studies, is that most of our patients are able to fast a substantial number of days in Ramadan when they are on insulin. And what more with this insulin analogs such as U300 glargine. So about 85% of patients were able to fast the entire Ramadan period, yeah, suggesting that they were not exposed to any extremes of hypo or hyperglycemia that require them to break their fast. When specifically looking at hypoglycemia, often we look at severe hypoglycemia and symptomatic hypoglycemia, and we are, familiar with the rates in previous, real-world studies and in other RCTs, and we can actually recognize that, there is not very much added increase in the rates of severe or symptomatic hypoglycemia during Ramadan compared to pre-Ramadan, and which is the fasting period. And certainly if we're looking at more severe levels of hypo below 3 during Ramadan in this study, there is definitely no. Of course, we institute the appropriate patient education, education about SMBG guidance, and even now with the use of technology such as continuous glucose monitoring or remote glucose monitoring, in fact, fasting with insulin has been very much safer. Yeah, and again, we appreciate the very low rates, event rates for hypoglycemia in this study, and which probably is now the norm when we are going to do studies of the newer insulins. Also, Ramadan is an opportunity to actually get better glycemic control, and along with actually not increasing risk of hypo, using these newer insulins, for example, glargine U300 here, has revealed that there can be some improvement in the HbA1c along with the fasting glucose, as well as the glucose that is measured by the patient. So basically in this study, it did show that using this form of basal insulin analog, insulin glargine, did really enable patients to fast safely with the most minimal rates of hypoglycemia. So there is another study also of a newer modern insulin. I won't also go to too much detail, but just to make us again aware that with the newer modern insulins, we will be seeing RCTs. And this is with IDEC aspart, which is actually Rhizodec. And we have this in Malaysia for the recent couple of years. So in this situation, it was compared to the other modern premix insulin, which is by aspart 30 or Novomix, both given in twice a day fashion. Yeah, and this again will reflect the profile of the patient, and we appreciate that they are, usually longer duration of disease, and prior to Ramadan, they already have an A1C that's not so optimal in the range of 8% plus or so. So comparing these two insulins, we already know that Novomix 30 already has a low rate of hypoglycemia. So what about IDEC aspart, when we recognize that aspart degludec has even a better profile in terms of minimal hypoglycemia and a longer action as a basal insulin. So essentially A1C, again, these trials also reflect the importance of the pre-Ramadan period, where we can actually get patients in the few weeks to months prior to Ramadan with good education, treatment adjustment, to have a better glycemic control at the start of Ramadan, and therefore not requiring and essentially being able to maintain this good glycemic control throughout Ramadan into the post-Ramadan period. Yeah, so we do see some difference in terms of fasting plasma glucose here in the two, but essentially what is most important to actually show is that the newer sort of co-formulation of this insulin is able to even reduce further the rates of hypoglycemia, which are already low. So we can appreciate here with the use of IDEC aspart twice a day compared to by aspart 30 at Sahur and at Iftar. Yeah, so again, it is so good that we have available and some of us are accessible to better choices of insulin to reduce hypoglycemia during Ramadan. And there were a few people in the global survey type 2 of the Dar Global Survey who were actually on these insulins. Yeah. So I won't spend too much time on this. So I've summarized that already. Yeah, so we have seen the Dar risk calculator, and we do appreciate that the element of treatment is actually contributing to quite a significant number of scoring. So to add to the final score, actually increase that score. Yeah, so being on multiple daily mixed insulin injections, higher score of 3, being basal pump of 2.5, and being on once daily mixed insulin, and certain is add to the score and ultimate fasting. Yeah. So how did this have a look at the Dar Global Survey in terms of those who were on insulin and their intention to fast? Many out of 5 people on insulin in the Dar Global Survey intended to fast and fasted, yeah, and this is high, and compared to the ones on SU and not others, yeah. When we look at the type of insulin and the intention to fast, and we can still appreciate up here is all the basal insulins, then here you have the prandial insulins, and right down the mixed insulins. And generally, we see high rates of fasting, intention to fast, actually, when you are on any sort of insulin type. Yeah, so there's really no difference. Yeah, so high rates of about 70% or more on different insulin types. So they were comfortable with whichever insulin type or regimen they're on, and they would fast throughout Ramadan, regardless of whether they were on human or analog insulin use. When it comes to insulin type and breaking of fast due to hypoglycemia, again, we're worried about use of human insulin and the fact that it may have higher risk of hypoglycemia. And also when we are on modern insulin, this hypo risk would actually be reduced. So looking at just the last column here in terms of percentage of those who are having hypoglycemia, we can appreciate actually there is some difference, but we don't see that the human insulin is actually increasing the risk of hypo. So overall, about 18% or 1 in 5 of those on insulin had to break their fast due to diabetes-related reason, and one of them would be hypo. And the rates of breaking of fast was lowest, in fact, for persons treated with human insulin. So maybe this points out that appropriate adjustments have been made in those with human insulin, together with monitoring, that has made actually breaking of fast due to hypos much less. So in those who had to break fast due to hypos, 2 out of 3 persons were on insulin, and these were actually the sort of percentages of those on different insulin types and whether they had to break fast due to hypos. So I'm finally finishing, and this is just the last 3 slides which re-emphasize the guidance from the Diabetes and Ramadan guideline about how to make the appropriate adjustments to either short-acting or long-acting insulin prior to Ramadan. Sometimes there is a need to do that, especially reducing the sahur dose to minimize the risk of daytime hypoglycemia. And also this is for the pre-mixed insulin. And there may be a consideration among us to actually really switch from human insulin to insulin analogs in certain subgroups of people, for example, the elderly, those with type 1 diabetes, those with a history of hypoglycemia, and also significant postprandial hyperglycemia. So ladies and gentlemen, thank you for listening. We already recognize that many individuals on insulin therapy elect to fast irrespective of their risk level and the advice of their physicians, such as us. And we are happy to know that there are better access to insulin analogs among insulin-treated type 2 diabetics, and this will definitely ensure safer fasting with less hypo. We also recognize that there are changing patterns of prescription of medications for type 2 diabetes, having newer medications such as DPP-4s, SGLT2s, and GLP-1s that have low hypo risk and are insulin sparing will definitely enable us physicians to prescribe more simpler regimens and lower insulin dose requirement, and therefore lower hypo risk, and make fasting in Ramadan safer. Again, I reiterate what everyone has been saying, that it's even if you're on whether you're on insulin, the risk is still actually able to be intervene with appropriate pre-Ramadan assessment, risk stratification done, assessment of intention to fast, and appropriate recommendations followed by diabetes education for lifestyle. And also SMBG is so important, especially now with technology available to make it more continuous and safe. So thank you very much for listening.